Hello everyone. Today I'll be presenting my case for a musculoskeletal concern in an adult. For my case, I've chosen a patient, we'll call him AA. He is a 24-year-old Caucasian male who presented to the clinic alone. He's a reliable historian, and his main complaint was that he's been having lower back pain for about 10 days. I know lower back pain isn't the most exciting concern, but it is an extremely common concern that's seen in a lot of different clinics, whether you're in a primary care clinic, urgent care, or emergency department. So I thought it would be a good one to do a deep dive into to get a better understanding of the differential diagnoses and how to approach lower back pain. So like I said, AA is a 24-year-old male. He comes in for a 10-day history of back pain that started when he was weightlifting, one of his frequent activities that he does. He was doing a deadlift when he felt a sudden strain in his right lower back and has had pain since that time. He does not have any radiating pain. He has not had any numbness or lower extremity weakness. He has no saddle anesthesia. He has no loss of bowel or bladder control. But he does have the right-sided lower back pain and a decrease in spinal range of motion. This has affected his ability to work at his job. He works at a koi pond factory, a koi pond shop, where he does a lot of maintenance and cleaning of different ponds and water fixtures. Pertinent medical history for him is pretty unremarkable. He doesn't have any history of back issues. He has no genetic components. He's never had a major trauma like falling from a large distance or being in a motor vehicle accident. He does have a history of breaking his multiple bones. He's broken his collarbone. He's also broken his wrist in his childhood, but other than that, nothing too pertinent. When doing a workup for AA, there aren't a lot of labs or radiological exams to be done right away. It's not indicated to do an x-ray or an MRI right away with lower back pain, although it might be helpful later on. To begin, I'll just start with the exam and physical exam and patient history. The history is very consistent with a lumbar strain, a lifting motion, especially if he's not using proper form with his weightlifting. For his physical exam, he is able to use full spinal range of motion, but he does have some discomfort with twisting motions in particular, and with a forward bend. He doesn't have any scoliosis. He has a negative seated slump test. His straight leg test was negative to rule out radiculopathy, and he doesn't have any decreased sensation or motor strength in his lower extremities. So with a clinical diagnosis of a lumbar strain, initial treatment plan is, let me go through my differentials. While I favor a lumbar strain, you cannot rule out a lumbar herniated disc right away. These are extremely common, although they're more common in older demographics, like age 30 to 50, and my patient's 24, so he doesn't really fit that demographic. However, he does have a pulling injury that could cause a slip disc in that way. He doesn't have any associated leg symptoms, which are common with a intervertebral lumbar herniation. And he doesn't have any numbness or radiating pain, which is also common with a herniation. So that's low on my differential, but if he does not improve with conservative measures with his lumbar strain, then it would be worthwhile to investigate a herniation with an x-ray first and then an MRI. A can't miss diagnosis with lower back pain as cauda equina syndrome. Uncommon, but not impossible, and something to be considered every time someone has back pain. Cauda equina syndrome is where inflammation on the spinal roots in the lumbosacral area become compressed and can lead to grave consequences. Commonly with cauda equina syndrome, you'll see saddle anesthesia, and loss of bowel or bladder control, and that can progress to a persistent and permanent loss of bladder, bowel, and sexual function if not treated emergently in an emergency department. I have very, very low suspicion for cauda equina syndrome in this patient, so I'll treat him conservatively for a lumbar strain first with strict follow-up precautions. Treatment for a lumbar strain is largely conservative. We will begin with activity modification, and it's activity modification, not rest. Rest is tempting when you're in pain. However, it's been shown to be not the best treatment because it can lead to decreasing muscle strength and stiffness, which can prolong pain and reduce return to work and increase work disability if you only rest and not use activity modifications and recommended stretching and exercises. Physical therapy is a mainstay of lumbar strains, so it's something that's recommended for AA. We'll give them a referral to get that started as soon as possible, ideally within 30 days of the injury. It's already been 10 days. Sometimes it can be difficult to get into physical therapy, so we'll emphasize that he needs to get on it and call the physical therapy clinic as soon as he can to get in. He can also treat with NSAIDs. He has been treating with ibuprofen, 400 milligrams every 6 hours, as well as ice therapy, but he's had minimal relief, so we can try a different NSAID. We're recommending naproxen, 220 milligrams by mouth with food twice daily. He's not to exceed 660 milligrams of naproxen in one day. He can also try heat therapy. Heat and ice both have their place in treatment of musculoskeletal pain. Since he's had only minimal relief with ice, we can switch him to heat every 20 minutes every 2 hours to help with his pain. He'll also do the physical therapy, and we'll give him some stretches and exercises today to do at home to help improve spinal flexibility, improve core and back strength, and reduce his discomfort. In addition to that, if he's not feeling better, if his pain's not improving in a couple of weeks, he's recommended to come back. So we can do a more comprehensive workup, including imaging such as X-ray or MRI that could elucidate different issues, whether it's a bony abnormality or other issue of the spinal cord or spinal anatomy. And he should follow up in 2 to 4 weeks if he's not improving. And if he starts having any of those red flag syndromes like loss of bowel or bladder control, saddle anesthesia, anything of that nature, he should immediately go to the emergency department. Or if he's just having significantly worsening pain, he can call the clinic and we can go from there. Thank you for listening.